Hello and welcome to our TIF Talk Tuesday. I'm Andrea Millers with Endogastric Solutions, and we're so excited to have you here tonight. We also have a very special guest, Dr. Kevin, otherwise known as Mac Cottingham. Welcome, Dr. Cottingham, and thank you for being here with us tonight. You're welcome. And we also have Karen Girth, who you've seen in previous TIF Talks if you are a regular on our TIF Talk show. She is here with us as well and will be helping answer, actually asking all the questions that we get tonight for Dr. Cottingham. So before we start, I do want to remind everyone this is a live event, and at any time, if you have any questions, please feel free to type them into the comment section and we will do our best to answer all of the questions that you have tonight. So we are coming to you from Birmingham, Alabama, right, Dr. Cottingham? That's where you're located?
Close. I'm in Pullman, Alabama, an hour north of Birmingham.
There you go. Well, before we start, I do want to give an introduction and let you know a little bit more about our special guest. Dr. Cottingham is a native of Birmingham, Alabama. He's always had a love for helping others in his community. He received his undergraduate degree from University of Alabama at Birmingham and his medical degree from the University of Alabama School of Medicine. Dr. Cottingham's postdoctoral training includes serving as a surgery resident at Baylor University Medical Center in Dallas, Texas. Dr. Cottingham opened his practice, Horizon Surgical, in 2009, where he is dedicated to providing state-of-the-art care. And he also loves spending time with his family and dedicated to serving his community at Coleman, or I should say in Coleman, Alabama. So again, thank you, Dr. Cottingham, for being here with us this evening. We really appreciate it.
You're very welcome.
So give us, before we start, why don't you, I know I gave you a little introduction, but tell us a little bit more about yourself and your practice.
Well, I was actually, to go back a little further, I did open Horizon Surgical in 2009. For the 5 years previous, I was actually in practice in Birmingham, Alabama.
Okay.
And just one thing or another led me here. The whole time I've enjoyed doing advanced laparoscopic surgery, which includes a lot of anti-reflux surgery. In the last couple of years, I've been getting deeper into robotic surgery, and that also allows me to take care of a lot of reflux issues. I do endoscopy as well, and so the taking up the TIF procedure has actually been very good, very rewarding, and I'm looking forward to talking about it.
Fantastic. Well, we're looking forward to hearing about it from your perspective, and hopefully we'll get some questions from patients that are watching as well and get some questions answered tonight. So before we, let's get started and talk a little bit more about GERD. Do you want to maybe talk about what is GERD and what could patients potentially, what types of symptoms they would feel if they were suffering from GERD?
Sure. This is a very common issue. The medications that are sold over the counter to treat GERD and prescription medications are among the most popular medications taken by human beings, especially in the United States. So it's incredibly common. But GERD is an abbreviation like we enjoy doing with medicine. We just abbreviate everything we possibly can. So it stands for gastroesophageal reflux disease. Right. And so when you just break that down, you're refluxing probably acid, but it could be anything, but usually acid from the stomach up into the esophagus. And it's a disease because it affects your life negatively. Right. It's very uncomfortable, and it can be anything from an inconvenience to a problem that could shorten your life.
Right. We hear from doctors often saying that GERD is sometimes trivialized, like you had mentioned about the over-the-counter prescriptions and people kind of self-diagnosing themselves and taking these medications. What is the difference between someone that's just, has occasional acid reflux versus technically having GERD?
Well, we like to eat different things, and a lot of the things that we eat are not necessarily good for us or pleasant when you reflux it back up. So, when somebody goes and eats too much pizza and then refluxes, but most of the time they're okay, that's probably somebody that has a package of some acid reducer at home that they break out whenever that occurs, but on a daily basis, it's not really affecting them. And some people have anatomical issues to where they are more prone to reflux, even on a good day, acid from the stomach. And in some people, it's almost constant, or it may be constant. And those people are suffering. And that's a completely different issue, and one that severely affects people's quality of life.
Right. Yeah. You hit you hit that in the nose, or however you say it. But to your point, right there you go, right there. Hit the nail on the head, kind of thing. When it affects your quality of life, right? That's when it's, because we get the question is, when's the point? What is the point where I actually need to go see a specialist, go see a surgeon or a GI to help me or help yourself with this issue. So let's talk a little bit about the different things that a potential person could do to manage their GERD kind of initially, because you had mentioned the PPIs or Tums or whatnot, but what other things can they do to kind of manage their GERD? Like, not lifestyle changes, you had mentioned, don't eat pizza too fast or too much, but what are the other things that they could do?
Right. Like, so your stomach, it's got a specific volume to it. And a lot of people eat too much. I mean, it's hard when you're enjoying what you're eating and there's more of it there. I mean, I do it. You just kind of keep going until you get a strong message from your stomach not to. And so that would be one thing, is just think more about the amount that you're eating. You'll have less pressure in your stomach that is forcing things back up. And another thing, it may be, if you think about it, certain types of food are going to affect you more, so avoiding certain types of food. Other things that people do who have more of an issue with it, they have a cutoff time toward the end of the day at which they will stop eating, so that when they lie down to sleep at night, you don't have loss of gravity, which causes everything to reflux back up on you. Some people sleep with the head of their bed elevated on some blocks or books or whatever. So you've got just a little bit of gravity helping keep things down in the stomach. And my wife did that when she was pregnant. Fortunately, she doesn't have that much of a problem all the time, but it was kind of neat because I felt like I was going to slide off the end of the bed every night, but you get used to it. So there's that. And then there's substances which relax your sphincter at the bottom of your esophagus. Caffeine is noted to do that, and maybe some other things like perhaps peppermint and a variety of things.
Right. Thank you. And if someone is suffering from GERD, what are the different diagnostic tests that they would go through to determine whether or not A, they do have GERD, and then B, if any treatment option would be the right choice for them?
Well, I see people, a little bit further down the line, people have been to their doctor. And
Sure.
so I'm sure a lot of people have seen their doctor, and their doctor felt like, hey, this is just somebody else with GERD. I mean, I'm going to give them a medication. And so I suppose they try that and they see if it works. But beyond that, like when they come back still complaining, hey, I am still having heartburn, or I don't want to take this medicine every day. When it gets to a severe point, we have options such as endoscopy would be one. Take a look. You have to be sedated for that in a GI lab, but it's pretty non-invasive. You just slip a little camera down the esophagus into the stomach and have a look. And you might see things like a hiatal hernia, which is an anatomic malformation which would encourage acid reflux. And you might see consequences of the reflux. You might see a stricture from long-term acid exposure at the bottom of your esophagus, which has caused scar tissue. Mm-hmm. And that causes like an hourglass effect. When you're swallowing things, you get resistance down there. Instead of sand, it's your barbecue chicken or whatever. And so it's slowing things down and you feel that.
Yikes.
Sometimes it's just inflammation. A little medicine will help reduce that. Sometimes it's scar tissue. And we would much rather people come in during the day to have this managed than in the middle of the night with something actually lodged in their esophagus.
Right, right. Well, thank you. So you had mentioned the hiatal hernia, and as a surgeon, I suppose I expect you fix the hiatal hernia as well as do the TIF procedure. Can you discuss a little bit more of how the hiatal hernia affects the GERD along with, the LES or the sphincter, if you will, how that kind of works together, and if you don't mind.
Right, sure. So to clear that up, LES, that's lower esophageal sphincter. And so that's supposed to be in the abdomen because the abdomen is a positive pressure zone. There's pushing going on there. And so if your sphincter is down there and you're pushing, that's being pushed closed too, and it's going to minimize your acid reflux. Now, hiatal hernia is something that is extremely common. And if I fixed every hiatal hernia I saw, I would just be doing nothing but that, and I would be extremely busy. But there are problematic hiatal hernias which cause severe acid reflux. And so that allows that sphincter to slide backward up into the chest. The diaphragm muscle is actually supposed to be like the wall between your chest and your abdomen. And certain things belong in your abdomen, certain things belong in your chest. And when part of your stomach goes up into your chest, that's a negative pressure zone. So you have suction there when you take a breath. And when you get that suction applied to your stomach with acid in it, then the acid will suction back up into your esophagus. And then you have that acid exposure and the heartburn.
Right. Perfect. Thank you for that. I like that analogy of the wall, the diaphragm as a wall. That's easy to understand. So before we continue, I see some questions popping up. I'm going to let Karen go ahead and ask some of the questions that are coming through.
Thank you. Hi. So we have Dr. Cottingham. A question from Michael. His question is: I've heard the TIF surgery described as making a flap that is akin to creating a door that opens and closes without a door frame for support. I've heard about lots of failed TIF surgeries. Could you address this, please?
Sure.
I think it's surgery. Durability and just kind of the mechanics of the procedure.
Well, since we've been talking about hiatal hernias, I think if someone has a hiatal hernia and it's not repaired and they just get a TIF procedure, that's going to be more likely to fail. And so this could, I don't know for sure, but this could possibly explain some of the TIF failures. And I'll add the overwhelming majority of TIF patients are extremely happy and they work very well. But it's not to say that for every single person it's going to be 100%. But Michael, so making the flap valve, I hate to give such a immature and unprofessional example, but if you're familiar with a whoopee cushion, this thing is magical. You blow air into it, you don't tie it, you don't twist it, but the air stays inside somehow. So that is almost like what you're doing with a TIF. You're just creating this valve that's very natural where things will come down into the stomach, but the configuration that the TIF accomplishes, it pushes the tissue together so that the acid does not come back up.
Yeah, similar to its natural kind of state of how it was originally built, right, Dr. Cottingham?
Yes,
To some degree.
What we, you know, the way they draw it in the anatomy books anyway. I mean, we see so many people who don't have that, so you start wondering what's actually normal. But what we think is normal is you do have that stomach flapped up next to the esophagus, creating that one-way valve.
Yeah, I love that whoopee cushion. That's perfect.
I'm
Go
sorry
ahead.
I don't have one to actually show you how it works, but maybe next time.
I can imagine what that would be like on a live show.
Excellent. Thank you for that. So I have a question from Laura, and she says, I did all testing, everything looked good, but almost every time I eat, I feel like food gets stuck in my esophagus. I don't feel acid. I feel like a plum hit in my chest or throat. And, her antacids are not working. I guess her question is, could she be a candidate for, or feels that she feels she should do?
You cut out for a couple of seconds there, but I think I got the gist of it. So for Laura, if she's experiencing these things and the testing so far has been normal, there may be some more testing that needs to be done. And it's a little bit premature to say she would be a candidate for a TIF because she could have certain problems that the TIF would make worse. So if you've got one of these rare entities like severe dysfunction of the esophagus that just doesn't push things down like it's supposed to, or if you've got a failure of that sphincter at the bottom to relax, if that won't relax, you certainly don't need to put more of a flap valve right there. So I wish I could tell her exactly what's going on, but I think that, perhaps there is a bit more testing that could be done that could possibly provide the answer.
Well, thank you. And then I have one last question, and I'll bring it back to you, Andrea. I have a question from Court, and he'd like to know what diet restrictions he will have after the TIF procedure.
That is a great question. The main thing is that you know that you're going to have them, and you are not going to go home from getting a TIF procedure and eat a cheeseburger. So it's a change over about 5 to 6 weeks. This could be another reason for a failure of a TIF. If somebody goes home and they immediately try to go back to barbecue and coleslaw. It's very tempting, I understand, but you just can't do it. So we want things to flow very easy in the beginning. So for the first few days, just to generalize it, you want things that would flow through a funnel extremely easy. And then after about 3 or 4 days, things that would flow through a funnel, with but it would take maybe a little bit less time. Then the next step would be things that you could force through a tunnel, and that would be probably for the next couple of weeks. And then when you get closer to a month out, that's when you're trying things that you couldn't get to go through a funnel. And it's all written out extremely specifically, and I don't think people want to hear the entire diet like word for word during this talk, but that's basically the idea. And it goes on, and it's about 4 to 6 weeks before you have no restrictions whatsoever.
Yeah, perfect. Thank you, Karen. I appreciate that. Let's talk about the different options or available options to date for the treatment of GERD. So you did discuss PPIs. Obviously, we're talking about TIF. There's the standard Nissen fundoplication. Maybe talk about all the different options that are available. As we know, not every option is the perfect option. Every patient is different. And then maybe talk about the differences of the options that are available.
Okay. Well, we already talked about lifestyle changes.
Yep.
And so medications would be the next step.
Yep.
And the first medications that we had were probably just antacid like Tums. And then they developed medications like Pepcid, the H2 blockers, which decrease acid produced by the stomach. And those were some form of a miracle. I mean, they've really helped medicine a lot. The PPIs, as you say, and that's another medical abbreviation for proton pump inhibitor. That's the pump that makes the stomach acid. Those work probably a little better than the Pepcid H2 blockers do. There are, of course, varying side effects, and we may get to that later on, but these are widely given to treat initially GERD. So for whatever reason, if that is not getting it for a patient and they need something else, you start talking about surgical treatments. And so historically, the gold standard is probably a Nissen fundoplication, like you mentioned. So fundoplication, you are plicating the fundus. What does that mean? So you're taking the floppy part of the stomach and you are essentially wrapping it like a valve around the bottom part of the esophagus. Natural? Not really. That's not normal anatomy. Does it work? It does work. It's good to control acid reflux. Unfortunately, because it's not exactly a natural configuration, there's some side effects to that. It can cause some notable resistance as food is going down. Most people who have reached the point of getting a Nissen fundoplication have had such terrible reflux. They don't consider it to be a failure if they've got a little resistance when they swallow certain things, because their life is still better because of that. It's a side effect that's notable. Another thing is almost no one who's had a Nissen fundoplication can burp or vomit. And in my patients that have had a Nissen, that's not an ongoing problem. I don't hear people complain about that all the time, but it's one of those things in life that you take for granted, being able to burp and vomit. I mean, it's nice to be able to do that.
Yeah. Perfect. Yeah.
And then the hiatal hernia repair. If you've got a hiatal hernia along with your acid reflux, you would need to repair that. And then probably the newest option that I know of would be the TIF. There's another procedure with magnets that goes around the lower esophagus that creates just a squeezing of the sphincter there. I'm really not an expert on that particular procedure, so I can't provide you with a lot of intelligent information about that one.
Perfect. Well, thank you. Do you want to talk a little bit more about how the TIF procedure works?
Sure. Well, it does. I typically repair the hiatal hernia. So I get the lower esophageal sphincter where I want it, and I get some esophagus down into the abdomen where I want it. And that gives you a perfect setup to do a TIF procedure. And so the TIF device, it slides over an endoscope, and the whole thing put together will go down the patient's mouth, down the esophagus, into the stomach. And so the TIF procedure will take that floppy portion of the stomach and position it where you would like it to be to create this flap. And then you will fire these polypropylene fasteners that will connect the stomach to the esophagus. And that process is repeated until we have formed that valve. And so that valve is not a wrap, really. That valve, it's more like a flap. And when you look at it after you've done it, it just looks like now your esophagus is invaginated down into your stomach. And so you've got like a squirrel trap or a fish trap. Food can go down, but acid's not going to go back up.
Yeah, perfect. That was wonderful. Thank you. And we talked a little bit about the diet, but what could patients expect for recovery of the TIF procedure? Kind of, are they in the hospital overnight? Can they exercise afterwards? You talked about the diet progression already. Maybe just give a little insight to that.
Well, every TIF I've done, I've also done a laparoscopic hiatal hernia repair at the same time. And so that person did have laparoscopic surgery.
Right.
TIF stands for transoral incisionless fundoplication, which is true. The fundoplication was incisionless, but the hiatal hernia repair was not. So these people, I do my hiatal hernia repair laparoscopically with some very small incisions. And so people handle laparoscopic surgery differently. I spoke to a lady by the elevator yesterday who I had done one on, and she said she had a little bit of a sore throat, but she really didn't feel like she had surgery.
Wow.
Other people will give you a different story, but I have let people go home same day.
Okay.
To be honest, that's not my preference. COVID and bed availability may have had something to do with that, but
Sure.
it was people were doing medically well, and these were not just 25-year-olds with no health conditions. These were like real patients.
Yeah.
And they went home and they did fine, because it's actually much less surgery than a Nissen fundoplication. It's a lot less surgery, a lot less insult to the patient, and so people recover actually a bit faster.
Fantastic.
They're ready to go home more quickly.
Yeah. Yeah.
I
What
would
about-
suggest people, like, you're getting a hernia repaired, so you don't want to go home and do squats and deadlifts. You need to take it easy for a while.
Perfect. Yeah, that was the next question. We get lots of questions about, can they exercise, walk, ride bike? Like you had mentioned, obviously you're not going to weight lift, probably how they got their hernia in the first place, right? But can they do, walking and probably not running? What's that time progression look like?
Yeah, walking as soon as possible, running when it's comfortable. And it depends a lot on how big the hernia was. If it's a small hernia, I'm not going to give people a whole lot of instructions on that.
Sure.
If it was a larger hernia that required a lot more work, and I'm concerned, I'll just, it's kind of patient to patient.
Sure. Sure. Karen, I'm going to ask you, do we have any questions that have come up that we'd like to ask?
We do. We have a question from Doug, and his question is, does TIF resolve your LPR symptoms, especially the breathing and burping part?
The LPR?
Mm-hmm. That's correct.
LPR. Can you fill me in on that?
The laryngeal pharyngeal, basically they call silent reflux, the laryngeal pharyngeal.
That's what the ENTs call it, right?
Yeah.
I would say I don't have data on that, but if you have silent reflux and in the night you have acid coming up doing these things, after a TIF, you're not going to have acid reflux most of the time. Like I ask all my patients, are you having acid reflux? And they say no. And I know that sounds a little bit fantastic, and I wouldn't sit here and say something that sounded like ridiculous like that if it weren't true. I mean, this is what people tell me. They say, I have not had acid reflux since you have done this. I mean, that's what I typically hear.
Yeah, so, and I've heard, Oh, go ahead.
I was just going to say, so those symptoms, I feel like it would control those. It really needs to be documented, though. I mean, if you're having those symptoms, like before you would have a TIF, you would need to have studies done to actually prove that you are having acid reflux. And if you are, I think the TIF would help.
Yeah, and I've heard some GIs say that one good way to know is if they put them on PPIs and those symptoms go away, that it potentially could be from their acid reflux. Hence, this could be, but to your point, would need more studies and testing.
You have to prove it.
Right. Karen, any other questions?
We do have one from Nikki. Are there any swallowing difficulties with TIF?
That's a good one.
I have not had any. And I think, I'm not going to say that that never happens, but I haven't had any. And just what the TIF procedure does, the way that it's made, it's just not made in a way that's really going to cause that a lot of the time. And I would even venture to say that if you're having swallowing issues, not that the TIF is not contributing, but it's probably linked to another issue. If an esophagus works like it should, a TIF is probably not going to cause swallowing issues. But that, disclaimer, it's medicine, so anything can happen, but I would say most of the time, no.
Yeah, perfect. Any other questions?
We do. We just have one from Scott. I've read that shoulder pain can be experienced in the days after TIF. Can you explain why and how long this lasts?
Okay. Well, I'll do the last part first. How long will it last? Probably 3 days. And why? In my mind, I'm thinking about somebody who had a laparoscopic hernia repair at the same time. That diaphragm muscle has some nerve fibers that for some reason short circuit with pain fibers around the shoulder. And so when that diaphragm gets sutured to eliminate that hernia, some of those pain fibers, they short circuit and you get the sensation that you've got some shoulder pain. You might not be able to say exactly where it is, but it's there and it doesn't feel good. People do not like it, but it does typically go away in about 3 days. I don't really see the TIF doing it that much because you're plicating the stomach to the esophagus, and if you're doing it right, you are not involving the diaphragm in that part of the procedure. But since the two go hand in hand, I think that's probably due to the diaphragm work and potentially inflating the abdomen with air during the procedure.
Good. Any other questions, Karen?
That's it for now.
Okay. I do see a comment here that has popped up on here from Christina, and you're asking about insurance. So Christina, I actually would love to chat with you about that. Maybe Dr. Cottingham, you can talk about the experience for insurance coverage in your practice, and then I can just make a comment about, she's asking, how can we convince the insurance companies to approve this procedure? What do our doctors need to do or code so the insurance sees it fit for patients?
Well, since all of my TIFs that I do have a hiatal hernia repaired at the same time, that's all like a bundle. And so I will tell the insurance company this patient has acid reflux, and we're going to do a hiatal hernia repair and a fundoplication. The TIF is a fundoplication, and so it gets covered, and I haven't had any problems with it. Say a patient, and they're out there, it's rare, but you don't really have a significant hiatal hernia, but you do have acid reflux. It's going to require a little more pre-certification to get the insurance company to cover that. And if I'm not mistaken, Endogastric Solutions has help with that.
Yep. There's a service called PRIA that can help, work through the pre-cert certifications for the TIF procedure. Yeah, it'd go through the doctor though, through you guys if you had one. So there are ways to do that. But Christina, if you're still watching, if you don't mind, I'd love to connect with you after the fact, and just chat with you and see what we can do to help you there. So with that said, Karen, are there any other questions that we have coming in from Facebook?
We have one more from Lori, and I think you might have touched on this, Dr. Cottingham, but she says, if a person does not have classic heartburn symptoms, rather, the silent reflux or like throat, sinus, ear issues, and PPIs are, will the TIF be successful?
You cut out.
Okay.
Yeah.
If PPIs are what?
Not effective.
Somewhat effective.
If PPIs are not effective, it might make it a little more questionable. But like I said before, do a pH study and see if the person is actually having acid reflux. And if you do a pH study like an endoscopy with a Bravo chip placement, and you've got a high score on that for acid reflux, then it stands to reason truly that the TIF would eliminate that acid reflux and help with those symptoms. Silent reflux is a crazy thing because we do see people sometimes with no symptoms, and we look in their esophagus and there are erosions in there or a stricture or something, and so it does happen. I don't really understand how it happens, but silent reflux is a real thing.
Yeah, perfect. Any other questions, Karen? Oh, her internet must be spotty.
One more.
Oh, there you go.
Am I back?
Yes.
Sorry.
Welcome back.
Yeah. I have one more from Carolyn, and she says, can you discuss pulmonary fibrosis in relation to GERD? Great.
Not very much. I'm not a pulmonologist, but you don't want acid in your lungs. I will say that. And so chronic bronchitis, I don't know if you can just say that was the cause of your pulmonary fibrosis. Probably not. But if you have pulmonary fibrosis, you definitely don't want to make your lungs worse. So if you are aspirating acid in the night, that would be a major cause of concern. I do get referrals to do anti-reflux procedures from pulmonologists. And I suppose to a large degree they are trying to protect the lungs. But in my practice, I'm not really conscious of a direct link between acid reflux and pulmonary fibrosis, other than you really just don't want the two of those coexisting at the same time.
Yeah, perfect. Well, thank you very much. We are winding down to the end of the show. Before we do conclude, Dr. Cottingham, I'd love to give you an opportunity to give your words of advice for those that are watching, that are suffering from GERD. What would you tell them to do, or what are the things that they should be on the lookout?
Well, I would just say if you've thought about, asking your doctor about it, then you probably should. And if it's not a major problem, he'll treat you accordingly. But if it's something that's significantly affecting your life, talk to him about it. And if it's bad enough, just say, "Hey, doc, this is why I'm here to see you today. It's because of acid reflux." It's tough for a doctor, like if you get hit with like 5 problems at the same time. It makes it hard to know like what's important. So if the reflux is real bad, just say, "Hey, I'm here to see you about reflux," and then they'll be more likely to take that seriously and get you the testing or the referral that you need to get tested.
Yeah.
TIF and most people, I would say, don't need surgery for their acid reflux, but the Nissen used to be our only option, and it's still a decent option, but in my mind, it's more of like for the worst patients, patients really suffering, and because a minor lap hiatal hernia repair and a TIF it's fairly easy on someone. Not to say you can't have complications, you can, but it's less surgery and it's easy to get over. This kind of opens the doors for those people who have acid reflux that bothers them consistently, but they may not have been serious enough to go after that Nissen fundoplication like a lot of people do who have more severe disease.
Yeah, kind of bridges that gap and allows you to treat more patients that are suffering.
I think so. And it probably would prevent some complications down the road, like perhaps a stricture or esophageal changes that would have occurred if they had been exposed to all that acid.
Yeah, perfect. Well, wonderful. I always say, suffer no more, right? You don't have to continue suffering. There are things that you can do to help you. So, well, Dr. Cottingham, we can't thank you enough for joining us. We really appreciate all of the words of wisdom, especially the whoopee cushion.
If we ever do this again, I'll try to have one on hand.
That's a good idea. That is a good idea. But thank you again. And before we head out, do you want to just remind everyone how they could get a hold of you if they're in your area and would like to schedule an appointment with you?
I have a website, horizonsurgical.org, and my office number is 256-736-2263, and it's just, you can look me up, Dr. Cottingham, or Horizon Surgical, and we'll be happy to talk to you about this.
Fantastic. It's also listed on your screen too on the top right-hand corner. So if you are in the area, you can schedule an appointment with Dr. Cottingham. If you are not, we do have a physician locator on our website, and it's gerdhelp.com. So you can put in your zip code or state, and you'll be able to find a doctor that's located near you. Again, Dr. Cottingham, thank you so much for joining us. We appreciate your time. And for all of those of you watching, thank you for joining us. We are here every Tuesday night, so we look forward to catching you next time. Have a good night, everybody. Thank you.
Thank you very much.